So we have a fair amount of time together, but also it is a pretty short amount of time to really talk in depth about the different sort of unique wounds and issues that we might see during disasters. So we are going to try to cover triage and disaster medicine for burns, smoke inhalation, heat stroke, drowning, cold stress, heat stroke, polytrauma, crush injury, and traumatic brain injury. So that's a ton. We're certainly not going to be able to go into everything super in depth, but I'm hoping that we will just be able to touch on everything a little bit, give you guys all a little bit of information about each of these topics. So you have heard about these issues before, you've thought about it a little bit, and then you can hopefully either come back to my talk here, because I will have extra slides and things that you can read about here, or you can remember a little bit of something I said and go look up things more, or you can consult with each other, or you guys are always welcome to email or WhatsApp me, or any and all of the resources you have available to you. Hopefully, if and when you're dealing with these issues, you'll have a little bit of a baseline to build off of. So, all of these different issues that I was talking about, they can all come together and even occur at the same time. So, if you guys are dealing with for example, a landslide issue, you could have downed electrical wires that lead to electrical burns, and you could also have pools of water leading to drowning. You could have animals that get heat stroke or cold distress. You could have all sorts of different traumatic brain injuries, or they could be crushed by the things that fall during the landslide. So, certainly, I think we're going to just try to talk about all of these different issues a little bit together because they can all be seen at the same time in one disaster in multiple different patients or in the same patient. Um, they can have multiple different issues at the same time. However, we can never escape our triage. So you guys may be sick of me talking about this, but I just want to remind you guys that every patient that you're examining and dealing with when you very first encounter them in a disaster scenario or in any scenario, we are going to want to triage them and attempt to stabilize them. And none of these scenarios that we're talking about today really change our triage exam, which again is an exam that's going to be done in about 2 minutes, and it's going to give us something to see if there's anything that's unstable that we need to directly address initially. And then after that, we will move on to addressing all of these different specific issues. But just again, to remind ourselves, our primary survey or our triage exam is something that we should be able to complete in 2 minutes as soon as we're able to evaluate that animal. If we have to anesthetize the animal in order to handle them and perform their exam and perform their treatments and diagnostics, we're obviously going to have to change things a little bit. But in general, if the animal is super injured or super compromised and we're just running up to them unanesthetized, we would monitor or look at their breathing, see if we see any abnormalities with how they're breathing and whether we need to intervene right away to try and improve their breathing. We are going to palpate for pulses, and we're going to palpate their core of their body and the distal portion of their body to decide if there is a temperature difference between the core and the periphery of their body that would indicate that there might not be circulating blood well between those areas of their body. And we'll also be checking their mucous membranes and pressing on their mucous membranes to see what their capillary refill time is like to show us how their perfusion is there. We'll see if when we feel their heart and we feel their pulses, are they both pulsing at the same time? Do the pulses feel strong? Do they feel bounding? Do they feel weak and thready? And then It is a little bit weird, as we have talked about before, and we'll talk about it again with traumatic brain injury being the very last topic that we talk about today. But weirdly enough, even though our brain and our neurologic system is really important, we look at our neurologic system after our respiratory and our cardiovascular system because our neurologic system is not going to look normal if we don't have a normal respiratory system and we don't have a normal cardiovascular system. If we're not getting oxygen and we're not getting blood flow to our brain and to our spinal cord and to our nerves, then our neurologic system is going to be abnormal. So we are, after looking at our respiratory system, our cardiovascular system, we're just looking to see, is our patient alert and able to look around and take in the world around them? Or are they completely comatose? Are they able to move all of their limbs? Are they able to breathe deeply as though the nerves that are supplying their ribs and their diaphragm work in the way that they should? And then the very last system that we would check is just the genitourinary system. So we know that if our urinary system cannot produce the urine, can't get it outside of the body, we can get life-threatening electrolyte abnormalities very quickly. We can also have prolapsed uteri and things, so we just look at that really quickly. So I know we've been over that before, but just wanted to remind us that, again, this is just a quick survey that we are doing, and if and when we are surveying all of these different areas, when we identify something that is unstable in all of those different organ systems, then we take action to try to stabilize them. And we've gone over that. We have different lectures that we can look back at on Canvas to go over, or if you want to review it with me a little bit more, you're always welcome to reach out and we can definitely do that because I am always happy to talk about our triage exam and just don't want us to forget that as our very first step, no matter what we're working on. And another thing that we have probably talked about before, and I know we have talked about before, that is related to our triage exam, is related to our emergency medicine, is related to our disaster medicine, is what's called our tree of life. So just wanted to remind you guys of this as well, because this is a good map to utilize to help us think through what is going wrong with our patient and what we need to do to address it or correct it in order to make our patient healthier and better. So this is called the Tree of Life because it is truly exactly everything that you and I, as well as our orangutan patients, need to be functioning normally in order to be alive. So this DO2 here stands for delivery of oxygen, and down here that stands for mean arterial pressure. So we need oxygen being delivered, and we need a blood pressure to deliver that oxygen in order for us to be alive. And if we break that down further, this CaO2 is the carrying capacity of oxygen of our blood, and that depends on the amount of hemoglobin in our blood, the saturation of that hemoglobin in our blood, and the amount of oxygen that's dissolved in our blood. That determines our oxygen carrying capacity, and our oxygen carrying capacity with our CO, which stands for cardiac output, that determines our delivery of oxygen. And that cardiac output and what's called our systemic vascular resistance, those together determine our blood pressure. And our systemic vascular resistance is determined by a lot of different hormones in our body. And our cardiac output is determined by the stroke volume of our heart, with the amount of blood going into it and pressing back on it afterward, as well as how well our heart is contracting. And our heart rate is determined by our sympathetic and parasympathetic nervous systems. So we have talked about all of these things, and if any of these things go wrong, then that affects the rest of the tree of life, and then we might not have a blood pressure or we might not have oxygen delivered. And that is the definition of shock, if we remember. And shock, every single animal and human on the planet went through shock in order to die. That is the common pathway to death. So what we're trying to do is intervene in this shock pathway and turn it around and get our patients stable again prevent them from going into shock and passing away. So again, these are all things I have gone over with you guys before. So hopefully some of this is ringing a bell, but if not, you can review that or reach out to me and we can review it together a little bit. So the first kind of unique disaster situation that we're going to talk about is burn wounds. This is definitely something we can see in disaster situations, whether these are what we would consider typical burn wounds. So a wildfire is going through a forest, or whether these are electrical burns, such as a downed power line or an electrical appliance getting stuck in a pile of water and leading to burns that way, or whether it's chemical burns if a dangerous substance was spilled because of an earthquake or something of that nature, and then that got on your patient. All of those can lead to burns and cause significant compromise and significant issues for your patient. So after we've done our triage exam, kind of concurrently, we'll be giving fluid boluses based on what we see in our triage exam. And we're going to want to get pain medication on board because this is a very painful process, a painful issue. And then we will want to check for other issues that might be going on. It's very common for an animal that has burns to have been injured in some other way with maybe broken bones and fractures or complex soft tissue injuries. That's one of the later things we're going to talk about in this talk is some pretty complicated soft tissue injuries, or they might have a traumatic brain injury or some thoracic or abdominal injuries. So we're going to want to check for all of those. As we are doing all of that, we're also going to want to look at our patient and decide how much of the body is burned. And in human medicine, and I think as far as I can tell, looking at orangutans and trying to make my best guess, but if anyone wants to work with us to do a study where we definitively measure this, we can definitely do that just to make completely certain. But there is this nice rule in human medicine called the rule of nines, where when they looked at the body surface area of humans, they can roughly divide the different parts of a human into percentages that are multiples of 9. So if the entire head is burned, that is 9% of that human's body surface area. And I think we can probably say that's about similar for our non-flanged male orangutans. So our younger males, our females, etc. We might have to consider it a little bit more in our larger males. The entire front of the torso is about 18%, so 9% together if it is burned. Same with if the entire back of the body was burned. Each arm is about 9% of the body surface area if an entire arm is burned. And each leg is also about 18% of the body surface area. If we are talking about a newborn human who is less than a year old, they have a really big head. So their head is actually 2 multiples of 9, 18% of their body. Same for the front and back of their body. They are about 18%, and then each arm is 9%. And there are some calculations that you can look up for in humans, and probably somewhat similar in orangutans, where for each 1 year they get older, you take away a percent from their head and you add that percent into their legs as they're growing for your general estimate for how much body surface area is burned. So this is a very long explanation. Why are we going through all of this so much? Because this is actually really important for how we treat burn patients and burn injuries. It also is helpful for us to know just exactly how serious what this patient is dealing with. So in human medicine, they have a lot of really good burn research and burn evidence and data. And so if more than 20% of the body is burned, then it's going to be a much more serious injury and they're going to have a lower likelihood of returning to normal function. And if more than 50% of their body is burned, they're going to have a much higher rate of mortality. And another important thing to note is that we should probably be looking at their body closely for the first 1 to 2 days, because they definitely can have burns that show up later, because the skin doesn't look completely burned with some chemicals, for example, until several days later. So it's just good to keep track of what's changing over time. But with the initial information that we get from our rules of nines, right away, we're going to want to use that information to help us figure out our fluid therapy for our burn patients. So what happens when there's a burn to the skin is essentially it's just like, I know this is gross, but it is like when we're cooking meat or cooking something on a grill. And so the burn is going to coagulate or basically cook a portion of the skin. And then there's an area around it that's called the zone of stasis. And then around that is the zone of hyperemia. And what hyperemia is, it means that the body is dilating blood vessels and sending a lot of extra blood flow and a lot of extra plasma and other healing components to that area to try and help that body recover. And so the body is sending a lot of extra fluid to this zone of hyperemia to try and provide the support it can to the zone of stasis. The zone of coagulation is already dead. There's nothing we can do about that. But the body is dumping lots and lots of fluid into the zone of stasis. So lots of bandages are going to get soaked through with plasma basically from this patient. They're just pouring fluid out of their skin because they no longer have a normal skin barrier. And so that means that patients with burns need way higher levels of fluids than you would ever expect. And so what we do is we use that rule of nines, we use that percentage that we came up with for that patient, and we will multiply either 2, 3, or 4 mils per kilogram times their weight in kilograms times the percent of their body that was burned. And then we're going to give half of that amount of fluid in 8 hours. So it can add up pretty quickly if you think about it. If you get a 50-kilogram female orangutan in, and say 20% of her body is burned, and you might give her 20 mil per kg, so a whole liter of fluids as some fluid boluses, because she seems unstable when you first rescue her out of the forest. But then you look at her body and you figure out, oh, she has 20% of her body burned also. So you ignore or you don't count the fluids that you already gave her in her resuscitation necessarily, but you would say, okay, she's not a baby, so we'll use 2 mils per kg, and she's 50 kgs. That's 100 mils right there, and then that's 20% burned. So that is 2 liters, and we need to give her half of that in 8 hours. So we need to give her another liter in that next 8 hours, and we need to give her another liter in the 16 hours of that after that in her first 24 hours. So even though she is not that big of a lady, 50-kilogram orangutan, we're giving her 3 liters of fluid in 24 hours. And what will happen is if we give her the right amount of fluids, if we resuscitate her adequately, then we will hopefully be able to keep alive that zone of stasis, and we will only have lost the portion of the skin that was actually cooked, actually burned by the burn, and we'll save it. If we don't give as that amount of fluids that we actually need, then we will unfortunately lose that. We won't get enough fluid to perfuse that zone of stasis and it will die off. And so then we're going to have an even bigger surface area that is dead and that's going to be sloughing off and having problems getting infected and causing pain and all of that. So it's really important that we follow our rules of nines, figure out how much is burned, and then treat that as best we possibly can. Another really important point, another thing to think about is we don't want to use colloids in these burn patients in the first 12 to 24 hours. So again, remember our colloids are the albumin that I know you guys use sometimes, or plasma is not a very good colloid, but it is still a colloid with some proteins in it. Or maybe if you use head starch or something like that, those are things that have large molecules to hold fluid and keep fluid in your vessels because it's leaking out. So it does seem like we want to use colloids because we are losing a lot of protein out of these wounds and out of these burn areas, but we don't want to use them within the first 12 to 24 hours because we're just going to lose it. It's going to all go into this zone of hyperemia if we give albumin or we give plasma or we give head of starch to a burn patient in the first 12 to 24 hours, it is all going to go to these zones of hyperemia and it's actually going to pull more fluid out because we're going to have even more protein there that can pull fluid and we're going to lose it all. And so you will very likely need colloids for your burn patients. You should spend that first 12 hours or so figuring out what colloids you have or what colloids you need to order or borrow or figure out where you can get it from because you will definitely need it, but you're just not going to want to use it right away because it will just pull more fluid out and cause more issues initially. And as promised, we're back to our tree of life. Just to remind you, so obviously burns can cause a lot of different issues, but in the very short term, in the very big issues that we are talking about here, we would be having hypovolemic shock. So we would lower the preload because we're going to lose so much fluid through our burns that we're going to be low volume in our blood vessels. And then our preload will be affected. So we won't have good stroke volume. We won't have good cardiac output. We won't be able to deliver our oxygen and have a blood pressure to live. And we will go into hypovolemic shock. Another thing to keep in mind with wounds after we do those first initial resuscitation times is that burns typically form what are called eschars. So this is what you can see here is an eschar. It's this really thick material. It's kind of like a scab. It's basically cooked together dead skin and colloid and everything all together. It is really thick. It is really, really tough. And it is just one of those things where unfortunately our patients' bodies have evolved to try and make this eschar, but it doesn't really help them. And especially if the eschar is, for example, across the entire torso, it can be like a straitjacket and your patient can be unable to breathe. Or otherwise, just there's a lot of damage under that eschar that is not going to be able to heal when the eschar is over it. So even though it is painful, it is really recommended to anesthetize your patient and remove the eschar as soon as it forms so that you can be flushing and keeping the wound under the eschar moist, keeping it looked at and treated. I don't know if you guys have this silver sulfadiazine in Indonesia or what it looks like. It almost always looks like this in the US. It's a very common brand here, but this is a cream that is very soothing on the burn wounds, and then the silver is also antibacterial. So we use that a lot after we remove the eschar, after we flush out the wounds. We'll then put the SSD on it. And then as soon as we're able to, if we can, we want to close that skin, just kind of take out that wound and close healthy skin together to allow that to heal so that we don't have open burn wounds that can get infected or cause any problems for our patients. But burn wounds are really, really tricky. They take a very, very long time to heal, and they can have a lot of different issues. And certainly, if you guys have burn patients, I'm sure you guys already experienced this and you know this. There are a lot of other cool things that can be done for burn patients, like putting fish skin on them to help them heal. There's a lot of cool different pain techniques. So there's a lot of different things that you guys definitely can look up and research because your burn patients will be with you for many months, unfortunately. So you'll definitely have time to look into that. But in the very short term, when you guys are looking at a burn patient, remember that rule of nines. Remember that you're going to need to get a lot of fluids in them. Remember that you don't want to be throwing colloids at them right away. And have in the back of your mind that you're going to need to figure out how to get those colloids and what you're going to do about getting their pain managed and getting their eschar removed and addressed. Does anyone have any questions about burn wounds? Okay, I'm
Yeah,
gonna go
yeah,
with
really
no, but you're all
sorry. This is just
yeah,
one question.
of course.
Wait, I'm running.
You can walk, it's fine.
Hi. Uh, Thank you so much. It's super interesting so far. What about hydrogel or intrasite gel? Is it indicated to dress the burn wounds, or is it better to always go with sulfadiazine?
I would say sometimes hydrogels can work out well. Um, I think some different wound types, some things that are called hydrogels are different depending on what they're doing and such, but a lot of those are to work to keep the wound moist. So my understanding is a lot of hydrogels are specifically made to help wounds that want to dry out remain moist. And that can be very useful. Certainly, we have to keep all wounds moist in order for us to get good granulation tissue and for them to heal well. But a lot of burn wounds don't actually have the problem of staying moist. They stay relatively moist on their own, and then the SSD acts as an emollient to hold in that moisture and to prevent bacteria. So that is why that one is often chosen, but it certainly is not the end all be all. It's not that you can't ever use other things. And if you're getting really dry wounds, oh, I have quite a lot of lightning here right now. If you get a lot of dry wounds or something, then yeah, you'll definitely want to use whatever you can to keep your wounds moist to encourage the best healing. All right.
Thank you,
Excellent.
Lily. And one more.
Yeah.
Okay, thank you. Hi, Lily. I want to asking about the scar. Yeah,
Yeah.
scar. Yeah. I heard about the scarotomy. They should be making incision or cut in the scar. After that, I want to asking about that. After that, should we stitch after make the incision of the scarotomy or just let it and membuang jaringan? Throw
No.
the necrotic tissue or not after the escharotomy?
Yeah, so escharotomies are tricky and scary because it's always hard to know exactly how deep everything is and how much damage there is. And it's going to really depend on what area of the body the eschar is on and how big it is. I would say in general, you usually are not going to be able to close your wound right away after you do an escharotomy. You're going to want to pull off your eschar and cut off all your necrotic tissue, and you're almost always going to have to manage your eschar wound, the wound bed below the eschar. You're going to almost always have to manage it open for several days to maybe even possibly weeks before you're able to close it. You also might not ever be able to close it. It can be really unfortunate if you get wounds on your limbs. It can be really hard to ever have enough skin to do a flap advancement or to close any sort of skin. You just might not have enough. But it's always great if you can and if you have the ability. But yes, certainly I can't think of any time. I'm not a burn expert, but I have dealt with a lot of animals with burns, and I cannot think of a time that we ever closed the wound right after the escharotomy. We just would remove it and have to manage the wound open for a while, maybe forever, or maybe until we have enough granulation tissue that we can do a flap advancement or some sort of closure.
Okay. We keep it in panel discussion. It's okay, Mas Agus? Or do you want now? Oh ya udahlah, kasihan nangis nanti nggak mau pula nanya lagi.
Thank you. Nanti tolong ditranslate ya. Tadi benar Eskar tadi menarik sekali. Kami ingin bertanya, pada kondisi tertentu kami bahkan membiarkan jaringan matinya itu untuk kondisi pada saat tertentu yang untuk bisa mudah dan lebih aman untuk diangkat. Dan kondisi ketika itu langsung diangkat agak mengkhawatirkan, kadang-kadang bisa luka cukup berat dan akhirnya malah lebih berat infeksinya. Pertimbangan kami seperti itu. Terus kemudian saya bertanya tentang beberapa tadi ada pertanyaan tentang sulfadiasin. Memang kalau kita tersedia sulfadiasin cukup bagus untuk luka bakar, tapi kadang di orangutan ini mereka biasa dijilat atau dimakan. Ini juga jadi pertimbangan kami ketika beberapa kasus kami akhirnya menggunakan yang ini herbal, menggunakan madu. Dan itu cukup efektif ketika kami menggunakan madu yang steril, dan selain dia bisa menggunakan dimakan, dijilat sama dia, dan itu juga cukup bagus untuk antiseptik. Jadi mungkin beberapa rekomendasi untuk antiseptik yang di orangutan itu agak sulit kita lakukan ketika orangutan ini yang tidak bisa dihandle dan cukup agresif, mungkin begitu. Terima kasih.
Okay. Lily, this is the translation, so don't worry.
Hello, Lily. Can you hear my voice?
Yes.
Yes. Okay. The first question is about the ash scar. It's quite interesting. In a certain situation, we indeed let the dead nerve tissue. We don't remove it right away because we think that might be dangerous indeed. And the next question is about the sulfadiazine. It can be good sometimes, but in many of our cases, many of these orangutans would lick or eat this, so we really put this into the consideration. So we usually just give more herbal approach. We give sterilized honey to the orangutans. We think it's a good antiseptic. So I think it could be good as the alternative antiseptic for the orangutan. Yeah, I don't know if that question.
Yeah. No, I agree. That all is, I definitely agree. In the ideal world, we would remove the eschar. It is going to give us the best chance for the wound bed to heal. But obviously, we're going to need to be able to keep that wound clean. And sometimes in our disaster times, if we don't have the ability to keep the wound really, really clean and prevent getting an infection, which could cause us to go septic and die, we do sometimes have the eschar there. It will delay healing if we do that, but sometimes that might have to be what you do. But you'll always want to check and decide if you need to do at least some cuts through the eschar to help make sure that things can move normally, like breathing, or if that's going to help make sure that a limb is going to be able to move normally, you might need to cut along stress lines for that. I've also had animals that like to eat the SSD cream. Thankfully, it's not too dangerous for any animal to eat SSD. And honey can also be a great option for wounds. There is good hydrogen peroxide activity in honey and a good hyperosmotic activity in honey. But sometimes a reason why burn specialists might want to avoid the honey is because it is hyperosmolar, so it does pull out more fluid. And so if if your burns are leaking a lot of fluid, then the honey will pull out even more fluid. But if it's not a huge wound that doesn't cover a ton of the body, that might not be a bad thing. The body might be able to handle that and just take in more fluid and be okay. I probably should have, please feel free to reach out to me if you want. Like I said, there are some really good studies that have come out on sewing fish skin onto wounds. I don't know if the orangutans would decide to eat that smoke sometimes from pollution and things like that. We're not talking about that. We're talking about having to take large lungfuls of really hot air with dangerous chemicals in it that unfortunately can be very rapidly fatal. And we need to think about different issues from the smoke inhalation. So the smoke and the heat can lead to direct mechanical issues. So usually that's going to be upper airway swelling, so swelling in our pharynx and in our nasal passages is going to cause an upper respiratory obstruction. And then we can also get chemical damage, and that tends to be things down lower in our lungs where it might kill off our cells in our lungs, the cells that make our surfactant. We might have the surfactant that is that covering that keeps our lungs open. It might get damaged by the chemicals in the smoke, and that can also lead to our lungs collapsing. So these are all unfortunate things that can occur. We can also get all sorts of nasty toxins from breathing in smoke. So we can get carbon monoxide, we can get cyanide, we can get too much carbon dioxide, aldehydes, all sorts of nasty things that we might have to think about. Here's some slides for you to come back and read about if you're interested. But we have to think about hypoxemic shock with our smoke inhalation, where we might have carbon monoxide or cyanide leading to our mitochondria not working. That would actually be metabolic shock, or we might have hypoxemic shock if we're just not able to get enough oxygen into our blood, or we get a methemoglobinemia, all of these things. And so we would want to give our patients oxygen to treat them. And we don't be afraid to intubate these guys, although unfortunately we may then be stuck needing to ventilate them. That's a whole nother discussion, but smoke inhalation is a really serious issue. Another issue we might see with these guys is electric or lightning burns and disasters. So then we are going to see burn injuries. We will also see seizures. We'll see electrical abnormalities of the heart. We might see muscle breakdown, and we might see non-cardiogenic pulmonary edema. All of these things we're going to cover later in my talk. So I just wanted to mention this as something, and it's going to cause all of these issues that we will discuss later. But if you notice on my earlier slide, the electric burns and chemical burns, we may need to give them higher fluid levels than your standard burn patients. And again, I'm really hoping we're going to get to this later, but I just want to also make a mention for checking out these burn patients and these smoke inhalation patients, checking out the color of their urine, because and any of these trauma patients, if their muscles are getting broken down from what's going on with them, and the myoglobin coming out of their muscles is going to their kidneys, that can really lead to a lot of problems and cause acute kidney injury, which we'll talk about later. So we want to keep an eye on that and see if that's something that might be happening. I've included this nice diagram that they use in human medicine in drowning patients to help them figure out how to treat the patient and what they need. This is the best algorithm that they have. So if and when you're experiencing drowning, I don't know how often you guys are experiencing cold water over there with drowning, but that is frequently what will occur over here in the US, is that because it is cold, it causes an automatic kind of gasp reflex, and then water gets into the lungs and causes problems breathing, but then also we get very cold. And so when a patient is cold, which can occur from drowning. It can occur from just being submerged in cold water or something during a natural disaster if they're pinned under something. Or it can also occur if they just get really, really ill, if they have gotten injured and they're not able to move or take care of themselves. We're going to talk later about complex polytrauma, and hypothermia, getting cold when you have a lot of trauma, is really, really bad. It's called like the triad of death. We'll talk about it. It's not good. So we definitely are wanting to get a temperature on our patients that are experiencing any of these issues to see what their temperature is. And unfortunately, if we are going to need to anesthetize them to handle them or take care of them, that is going to cause even further issues with their temperature. And so definitely getting a rectal temperature or an esophageal temperature and keeping an eye on that is going to be really important, and doing everything we can to maintain their body temperature, whether that's keeping them wrapped in blankets, putting warm water around their body, keeping socks or something on their limbs to keep them as warm as possible, trying to move their body a little bit to keep their muscles moving if they're not injured in those limbs. And another thing to watch out for on their ECG is something called a J wave or an Osborne wave, where they might, after their QRS complex, get this little divot. It's called a J wave, and it's not 100%, but it is pretty consistent with hypothermia. So if we're seeing that, that's something we have to be pretty concerned about. Another thing to be thinking about, if you have a patient, whether from drowning, whether from complex trauma, whether from any of these other things, that is very, very cold, we need to keep in mind that that level of cold, it can be a big issue. We want to avoid what's called the after drop phenomenon. So what that would be is, if we're warming the patient up, we're starting to give them fluids, we're getting everything circulating. If they have had all their blood vessels really constricted out in their periphery, and their blood has gotten really, really cold out in their toes and fingers, and then we send it back to their core, then that can suddenly drop the temperature of their heart, their liver, their kidneys, all of that really, really quickly, because the body works to maintain as much blood and as much warmth towards the core as possible. So we can actually make things worse if we warm things up too quickly or try to warm up the limbs in the periphery. So you're going to want to only warm over the core and kind of do slow resuscitation with your IV lines as close to the core of the body as possible, so that when that blood comes back in from the distal parts of the body, it gets warmed, because you have really strong warming going on in the core parts of that animal's body. So whether that's giving warm air through their breathing tube if they're intubated, whether that's warm fluids, whether that's a really forced air hot blanket or warm water blankets or something, you'll definitely want to do that. And we also have to keep in mind that if we're doing like CPR or giving any medications, a lot of medications don't actually work in a really cold body. They just don't bind to the receptors that they need to. And so atropine and epinephrine don't really work below 94 degrees Fahrenheit very well. They still recommend that you give the epinephrine. You'll just give it less often if you're doing CPR, because when the animal starts to warm up and everything starts to work, you do not want them to get hit with a ton of epinephrine that all of a sudden is working. And you do not want to give atropine at all until they are above 95 if you think that they are needing that. And I just put in some of my lecture slides from last year when we were talking about respiratory triage and respiratory issues and how to intervene for that. So this is definitely something you might need if you have a patient with burns or smoke inhalation or cold stress. So I just put those all in here, but since we have had a lot of good discussion already. I'm just gonna skip through most of all of these, but I did also just want to remind you from last year that we talked about if you have the ability to do a blood gas or take a measurement out of the blood, ideally from the artery, but even from a vein, to check the oxygen content in the blood, that can be very useful. Or if we can't do that, we do also just want to remember that our pulse oximetry, that nice handy tool that we have to put on the tongue or on the lip or something like that to check out what our oxygen concentration in our blood is, that number really tanks as we move down. So if we have a pulse ox of 99, 98, we have good oxygenation in our blood, but even a drop down to 90 brings our oxygen level of our blood all the way down to 60, which is quite low. If we remember, we would want our oxygen to be around 100. So for it to go from 100 to 90 on the SpO2, but 100 to 60, that's a really, really big deal. So that is why when you're looking at your pulse ox, if you're getting a number that's below 95, you really want to readjust the pulse ox, see if it's just that the tongue got a lack of blood flow or something, or is this patient really having a very low pulse ox? And then that's a big problem that we need and want to address. And here's just those numbers in a table format rather than in a graph format. And again, these are from last year, just some things we want to think through about what to treat an animal that is intubated and getting CPR. I thought I would mention here too, if we have the Eshar that is preventing us from breathing well, that might be also something that we need to cut during our CPR in order to better release the chest and allow the animals to breathe better. And just another reminder from last year, our doxapram is something that creates more oxygen need in our brain. So if there is a reason that we're not getting enough oxygen into the body, then we don't want to give doxapram because it's just going to make our body feel like it needs more oxygen when we can't get more oxygen in there. So it's pretty rare that we want to use doxapram. It tends to be something we're using in like premature babies and things like that. And it would be pretty rare in these sorts of disaster scenarios we would ever want to use doxapram. All right. Next, we'll talk about heat exhaustion and heat stroke really quick because we are after we talk about hypothermia, we can also talk about hyperthermia. There's 3 different ways that we can move heat throughout the world. So we can radiate the heat just off of our skin. We can evaporate it by panting. Even animals that don't pant like us and like orangutans, we still can lose a fair amount of heat through our respiratory system, or we can maintain or hold on to a lot of heat through our respiratory system. If it's really hot, humid air that we're breathing, we may want to be able to breathe off some of this air and the heat through water, and we might not be able to. Convection would be like getting airflow by you from a fan or something and you're sweating, and so the sweat molecules help take the heat dissipation off through the airflow that comes by. And then conduction is truly just touching an object. And when you touch like a cold metal table, that is because the metal table is pulling warmth from you, and that's why it feels cold. So those are the 4 different ways we can get rid of heat that we want to keep in mind if we have a patient that is coming in with heat stroke. There's a lot of different things that can make an animal more prone to heat stroke, but I think in your guys's situation over in Malaysia, Indonesia, the rest of Southeast Asia, a lot of times it is literally just the weather around there that could be leading to heat stroke, especially if the patient is injured and just cannot move and is unable to move out of the elements and just gets bombarded by the elements and gets overheated. But always good to remind us that we could be having a fever if we have an infection or seem to be feeling ill, obviously we could have a fever, but then hyperthermia, when we just have too much heat gained and not enough heat loss and we feel completely overheated, that would be when we're dealing with heat stroke. It'll start mild with just heat cramp and muscle spasms. It will follow into heat exhaustion. So then you might start getting diarrhea in your patients. They might get really weak, and then it'll go fully to heat stroke, usually around above 104 degrees Fahrenheit, 40 degrees Celsius, and we will start to get multi-organ dysfunction. And again, just kind of like burns, we are kind of literally cooking our body. And so it likes to cook things that are very metabolically active. So that's going to be the cells that line our GI tract. That's going to be our bone marrow. That's going to be our brain, are going to be some things that are really, really prone to heat stroke. Our very first initial treatments are going to be to use all of those different methods of heat dissipation that I talked about to try and get the patient as cool as possible. There's a lot of debate on whether you should use ice or whether you should use cold water. I think you should just use whatever you have available. If you have ice, I would definitely put water in and ice together, and I would use that to put it on the central portion of the body, again, the core of the body, because if we put it on the periphery, on the arms and legs, the body is really good at constricting those blood vessels and making them small, and then just shunting all the blood to the core. And then all that really hot blood is going to be in the center of the body, causing problems. So we want to put all this cool material in the core of the body. And so we can absolutely just douse them continuously with cold ice water. We can get fans blowing on them. If it's really, really severe, you could consider putting some cold water like up the rectum. Giving just IV fluids is a really, really great way to get them cooled. If you guys have ever noticed, IV fluids, even if you try not to let an animal get cold, they will get pretty cold with even room temperature fluids being given into them. So that can actually be super, super helpful in a heat stroke when you're trying to get them cool. But it is also really important. So if an animal comes in with a temperature of 105, 107, I've seen it at 109, 110, that's really, really scary. And we do need and want to get that cooled off as soon as possible. But we also have to keep a very close eye on that temperature. And we need to stop cooling at 100 degrees Fahrenheit or 38 degrees Celsius, because they're going to keep plummeting. So it will be even worse if they were really, really high and then we cool them way, way too far down below that. So you need to stop cooling them before they even hit a normal temperature, because they are going to continue to drop down. And you need to make a good plan to make sure you're going to be able to get a good temperature. So if you are putting fluids in the rectum, you're not going to be able to measure the temperature in the rectum. You're going to need to make sure you have an esophageal temperature probe, for example. Or if you have if you're going to need to use the rectum as the temperature area, then don't be giving fluids in there, because that will negatively affect your ability to measure the temperature and keep track of what's going on with your patient. And so in all of these different cases of like heat strokes and burns, I just want to remind you that our shock is going to look different than it typically does. So if you get a patient that is hypovolemic, so they've lost a lot of blood or they lost a lot of fluid from their burns, then they will look vasoconstricted. So they're gonna shunt all their blood to their core, and they're gonna have cool periphery, and they're gonna have a really rapid capillary refill time, because they're really constricted there. However, when they're really overheated from burns or they're experiencing heat stroke, you're going to actually see the opposite, where they're going to have super, super red mucous membranes, especially if they have like cyanide toxicity or something. They're going to be extra hot. They'll be warmer on their paws and out in their fingers and toes than at their center portion. And so that's very different than the typical shock you can see. where again, like if we see a typical hypovolemic shock where if they had diarrhea from their heat stroke or they lost a lot of fluid from their burns, then you'll see the more typical. And then metabolic shock, if they get cooked and they don't have any glucose and they're using a lot of oxygen, they will again look maybe like a mix of between these two. So lots of things to consider. And here's just a table for you to look back on and look at what typical shock looks like. And then what I have marked in the blue is those kind of rare times when you might have heat stroke or a pheochromocytoma or some sort of vasodilatory shock that'll look a little bit different. And this is when we're talking about this kind of shock, it's called a distributive shock. And it's a shock where the blood vessels are really, really dilated. And so the blood's not able to move through the body because there's not good hoses to send the blood through. Instead, they're big and floppy hoses. So that is how we go into shock with these disease processes. And in these disease processes, we're going to want to run some blood on all of these patients, and we're going to possibly see low red blood cells because of their diseases, losing blood from their injuries, or just because they're chronically ill. In hyperthermia and heat stroke specifically, because we cook the bone marrow, we are going to see nucleated red blood cells often. And the more nucleated red blood cells you see, at least in the patients and the species we've studied so far, that equals a worsened prognosis. So if you're seeing a lot of nucleated red blood cells, like we are seeing in this picture here on your blood smear, you're going to know that unfortunately your patient is a lot more serious. We are also going to see a thrombocytopenia, so low platelets. Again, in a heat stroke, this is because we have cooked our bone marrow, and so all of our macroplatelets, all of our cells that make our platelets have been cooked and have died off. But in our burns and things, we're going to be trying to send those platelets to try to stop any blood flowing out and any issues, and we're going to lose our platelets that way. We definitely can see our electrolytes go abnormal. We can see high liver enzymes. We can see high kidney values, and we can see low glucose. And if you guys have any way to measure clotting times, or if you just even look at a normal blood tube that you pulled for a chemistry, it may take a very long time to clot because our blood just is not going to clot like normal after such a severe disturbance and issue. So again, we know we're going to give fluid boluses, as we've talked about with our shock before, and then we can get colloids in right away if it's not a burn patient, or we'll wait until about 24 hours later if it is a burn patient. And as we've talked about briefly before as well, a lot of these patients are going to be really, really sick. And so if they seem to be in shock that doesn't respond to our fluids, if we've checked electrolytes and fixed their electrolytes if we can, then we may need to talk about putting them on a pressor medication to try and maintain their blood pressure and try to help them out of shock. We're also going to want to give them oxygen if they need it. Do not be afraid to intubate a patient if you think they're needing it, if they're having trouble breathing. And we might need to give them plasma if they're not clotting well. And we might need to treat them. We're going to talk about this in the second half of my talk, but a lot of these patients with these issues are very prone to having their kidneys stop working. And so we are going to want to make sure that they're making urine. And if they're not, we may need to treat them to try and keep their kidneys functioning and making urine so that they can flush out all these toxins and all these things that are going wrong in their body. They might need dextrose if their glucose is going really low when all of this is happening. We might need to keep them elevated with their head above the rest of their body if they seem to have brain swelling. Hypertonic saline can be really good to help them with that. We'll talk about lidocaine with anything that might be going wrong with their heart. We might need to support their liver if it's not happy based on everything that's going on. And in any of these disease processes, it's generally a good idea to treat them for any nausea. It's never good if you're having trouble breathing or if you're having issues to experience an increase in abdominal pressure from vomiting or feeling nauseous. And then also obviously we are prone to, if they're vomiting or regurgitating, they might breathe that into their lungs, and that can be a really big problem. So it's pretty much always a good idea to give them anti-nausea medications if you can. It is less clear if we should always give them ulcer treatments, but if there's any sign that they have ulcers, we should definitely treat it. Or if their liver is really failing or their kidney is really failing, then it is probably a good idea to give them ulcer treatment, because both of those are going to make them a lot more prone to getting ulcers. And so we want to try and prevent that if we can, because that will just cause more issues. All right, so I know we started late, so I tried to breeze through that pretty quickly on those things. And so I think I can just take any questions you have, and then we can just talk about complex trauma for my next talk.
Thank you, Lily. Please give applause for Lily. Why are you so silent? So, Lily will be continue the session after the lunch, but we still have a time now. We have 5 minutes. So I offer to participants who want to asking to Lily.
Thank you for your presentation. It's really interesting. I just have a couple questions. How fast do you usually warm hypothermic patients up? Like during a couple hours, like how fast?
Yeah, I'm sorry that every time I answer a question, I say it depends, but obviously that is often the case. But we are going to try and warm them up to at least 94 degrees pretty fast, because we need them to at least be at 94, 95 degrees for them to, again, have basically everything in their body working. The drugs that we want to give them and all of their hormones and just all of the normal physiology in their body, we're going to want that to be pretty fast. So I would try to get up to that temperature as quickly as you can. It's sometimes frustratingly slow. It can sometimes take a couple hours to get it to that temperature, even if you're trying really hard. But also sometimes you can do it within 30 minutes or an hour. After that, then I think what you're getting at with your question, which is a really smart and good question, is sometimes there is some evidence that says that if you warm up a patient slowly, it's better for their brain. Kind of having what's called permissive hypothermia, or having them a little bit colder than normal, might be better for their brain. I think that in wildlife medicine and even in our veterinary patients, like our dogs and cats, we don't have enough evidence to say that that's really, really beneficial in them yet. And I also think that in dogs and cats and in orangutans, they don't have to read newspapers. They don't have to do as many complicated things as we ask human patients to do, where they're really evaluating their neurologic system. And a lot of the patients that I see that we see coming in, they're going to actually have had enough damage to their brain or other parts of their body that they are really going to struggle to maintain a normal body temperature anyway. If we don't support them and if we don't give them external heat sources, they don't really maintain a normal body temperature. As soon as we take it away, they drop back down. And I feel like I see that typically for the first 24, 48 hours of their hospitalization, pretty typically. So I don't worry too much about warming them up or too quickly, because I just don't find that happens too much. You guys should tell me if you experience something different, because I think you guys have a very different climate there than I do. So maybe you guys experience something different, and please do teach me about that. But I would say that I don't think you have to worry about warming them up too quickly. Like, just focus on warming up their core and do it as quickly as you can with what materials you have available. And usually it's going to end up being enough where they are going to warm up in an hour or two at a good pace. And you're just going to want to keep a really close eye on their temperature because of that after op phenomenon. And also, just like with cooling them in heat stroke, you don't want to over warm them. So you'll want to stop before they get too warm. But also, you probably don't want to stop all of your warming because, like I said, I have seen it where they just aren't ever able to maintain their temperature. So you're going to have to leave some sort of support on them to help them be warmer.
Okay, thank you so much. And the next, I just want to ask, what kind of dextrose do you usually use to maintain glucose? I know depend on the patient and everything. I just heard from some vets that they use 5% glucose, and I'm struggling with this question because I learned that it cannot maintain glucose. What is your opinion? And yeah, I just would like to hear your opinion.
Yeah. So I am very spoiled here, and I always give my dextrose based on what the patient shows me they need because I have a glucometer. So if you have that, I really like giving the dextrose and then checking the glucose afterwards in 15, 30 minutes, an hour to see what our response is. If I think it's something temporary where I'm not going to need glucose for a long time, I will give a 0.5 ml of dextrose per kilogram, diluted 1:4. And so that's a 50% dextrose solution that we get here in the US. So I'll dilute that 1:4, and it would be a 12.5% glucose solution. And I just give that as a bolus, and then I'll check 15 or 30 minutes later and see if our glucose came up, and then I'll check in a couple hours and make sure it's maintaining. If I'm able to kind of start that patient on tube feeding or get that patient eating, and I think their glucose is going to maintain. Otherwise, if I'm giving it IV, I have to think really carefully because dextrose can really make veins very unhappy, and then your veins are going to get hurt and not get the fluid flowing through them very well if you have really high percent dextrose. So I like to start at 2.5% or 5%, and I don't really like to go over 5% in a peripheral vessel. If I am going over it to 7.5 or 10 or even 12.5%, which sometimes I have to do, I like to do it in a central line, so a jugular or a femoral or something that's a bigger vessel that's going to move the dextrose through right away and hopefully not get damaged by it as quickly. So sometimes I do have to do higher levels, and I'll do that. If I really can't get a central line in, then I do like to see if I can have like multiple IV lines in and giving 5% through both, or I just have to watch that IV line really closely because the higher percentages can be really hard on the blood vessels.
Okay, thank you so much.
Thank you, Daria. So we still have a 2 minute. Hanita, she's from SOC.
Okay. I have two questions. For you. I have asked about the burn wound. How about using a skin flap in the damaged area? Is it possible to do it also in the scars area? And also the second one in about the smoke inhalation. So from what I know, but please correct me if I'm wrong. Usually, one of the effects from the smoke inhalation was inflammation in especially the upper area of the airway, and also in the trachea. So you said that we need to put the oxygen in the patient, but how to avoid get the trachea obstruction when we got to the ETT, because the inhalation, if the swelling is very severe.
Yeah. So I'm going to answer your second question first because I already forgot your first question. So we'll go back to that. But the second question, yeah, it's definitely something you have to think a lot about and make up a good plan for with the upper airway swelling. And usually it is kind of an emergency situation. So you're just figuring it out as you go. So I will sometimes even just put a very small, like red rubber tube, if you know what that is, or a very small tube down the trachea if it's so swollen that I can't get a normal ET tube in. At least I can get some oxygen down through that tube, and then I can sometimes feed the ET tube over that. And or you can also, unfortunately, sometimes we have to do a tracheotomy where we cut open the trachea and put something in there if we're too obstructed and too swollen up in the pharynx and the mouth region. So those are all things that happen sometimes. If we're really swollen up in the upper airway region, I think we should ask Dr. Jen. I bet she might know even more things than I do about all of this. But sometimes I like to aerosolize or have them try to inhale some hypertonic saline. I find that can help. Sometimes also there's some evidence that if you aerosolize furosemide, Lasix, it will also decrease swelling in a different mechanism of action than the way that it works when you give it IV, IM, or anything like that. Or sometimes we'll give steroids, all of those things to try and decrease that swelling so that you'll eventually be able to pull the tube out and hopefully have that animal breathe a little bit better. And then can you remind me what your first question was?
Okay, my first question was about do a skin flap in the damaged area of burn wounds, and also can we do that? And also, is it possible to do it also, especially in the scars area when scars are already formed?
Yes. I would say if you're going to close the wound where an eschar previously was, a wound flap is almost always what you're going to have to do. And obviously there's a lot of different wound flap techniques depending on the different area of the body that's affected. But yeah, you're thinking exactly correctly, where if you're going to try to close one of those large burn wounds, a wound flap is almost always going to be what you're going to have to do.
Okay, thank you very much.
Okay, I think we are enough for the question in Lily's session. So we will continue with the panel discussion. So Nabila will be leading this session. So during the preparing for the panel, I'll be giving Jennifer to giving a little bit comment about the inflammation on the upper respiration because of the smoking inhalation.
Yeah, and this first thing isn't specific to smoke inhalation, but in babies, for example, who have acute swelling in their airways, we'll have them inhale racemic epinephrine because that will often open it up, but mostly we use steroids, especially IM, so it's slowly diffusing out into the system.
Okay, thank you. Nabila?
Okay,
I offer to you now.
Thank you very much, Lily. Thank you, Yenny. So now I would like to invite Daria and also